Okay, I think that it is 11, so we're going to begin this webinar. First of all, just thank you to everyone who's joining us on the webinar this morning. This webinar focuses on the health response for refugees and IDPs during COVID-19 in Syria. I'm Kat Fallon, and I'm the Advocacy Advisor at MedGlobal. And I think as many of you know, MedGlobal is an international health and humanitarian organization, and we work to serve communities by supporting sustainable, innovative, and free healthcare services to refugees, displaced people, and vulnerable populations in crisis areas and low resource settings. We work in crisis-affected areas in collaboration with local health organizations. We focus on capacity building and providing humanitarian and medical assistance. And ultimately, MedGlobal aims to create a world without healthcare disparity. So in the midst of this deadly global COVID-19 pandemic, we're working in coordination with our amazing on-the-ground partners to host this webinar series, which focuses on the global health responses for refugees, IDPs, and vulnerable communities in Colombia, Syria, Greece, Bangladesh, Gaza, and Yemen. So as I think most of you know, there are over 70 million forcibly displaced persons and refugees in the world, and we know that they will be hit the hardest by this COVID-19 pandemic. So of course, these communities must not be forgotten. This particular webinar focuses on the COVID-19 response in Northwest Syria, including the challenges, coordination, and key needs of health workers and communities. In Northwest Syria, fears have been growing about the potential impact of COVID-19 for millions of displaced men, women, and children, particularly those in overcrowded camps. There are around 4 million people in Northwest Syria, primarily in the Idlib governorate and in northwestern Aleppo countryside, and about half of those people are internally displaced persons. And over the last 6 months or so, a recent massive wave of displacement has resulted in around 1 million people who have been newly displaced around between December 2019 and just this past February, many of them for the second or third time. So of course, this makes them particularly vulnerable. The health system in Northwest Syria has been completely fractured over the past 8 and 9 years from systematic targeting of medical facilities, and the conditions in the IDP camps in this area are very dire. So given all of this context, I'm going to turn it over to our first speaker, and that is Dr. Zaher Sahloul. Dr. Zaher is the president and co-founder of MedGlobal, and he just returned from January from a medical mission to Idlib, Syria, where he visited local humanitarian partners, met with newly displaced persons in IDP camps, and treated patients in the largest hospital that's remaining in Idlib. He is the former president of SAMS, the co-founder of ARCS, and the co-founder of the Syria Faith Initiative. And Dr. Zaher sits on the advisory board of the Center for Public Health and Human Rights at the Johns Hopkins University Bloomberg School of Public Health. He has also authored many articles about the health response in Syria and other emergency crises, including in the New York Times, The Guardian, The Independent, and more. So Dr. Zaher, over to you.
Thank you, Kathleen, for the introduction and for the timely webinar. My current focus actually is taking care of my patients in Chicago. My specialty is pulmonary and critical care medicine. This is a virus that is affecting the lungs in particular. So patients come to my hospital with shortness of breath and respiratory failure. They end up in the intensive care unit very sick. Many of them require to have air tube and put on respirators, mechanical ventilation. And unfortunately, no matter what we do, some of them don't make it and die. Patients who have chronic conditions like diabetes, hypertension, obesity in particular, chronic kidney disease, cancer, chronic lung disease, heart failure, and patients who are older, more than 65, tend to do worse. And the death rate is higher among these population. So my hospital is right now struggling to deal with this pandemic in Chicago. In my hospital, we have 250 ventilators. And I'm gonna just mention this number to put it in the context. We have in my hospital in Chicago more ventilators than Idlib and Gaza and Syria combined, all Syria combined. And that will give you an idea about the resources that we have in the United States. And in spite of that, we are overwhelmed. So imagine what happens in an area like Idlib, where you have 3.5 million people, half of them displaced, 1.2 million of them live in camps. I was in Idlib in January, following this large displacement that you mentioned of more than 950,000 people because of the bombing, the Russian and the Syrian regime bombing in southern Idlib, which led to further displacement of the population towards north sides. And that caused, I've seen people crowded in very small spaces in temporary shelters. You have 2 or 3 families, 20 people in small rooms. In the camps, there is more than 1,250 camps. I mean, this is biblical number, 1,250 camps. Some of them have 50 tents, some of them have 2,000 tents. And in every tent, you have between 10 to 20 people. So when we talk about preventive measures that are now well known to everyone, which is social distancing, how can you social distance yourself if you are in a tent with 15 people? It's near impossible. Dr. Walid Tamer, who's the director of health in Idlib, I was speaking with him. He was on a webinar last week. And he told me that he saw this patient. She was young and he suspected that she has COVID-19. And based on her x-ray and symptoms, she had shortness of breath, fever, and cough. And he recommended that she self-isolate herself. She looked at him and she said, how can I self-isolate myself? I live with my family in one tent. We are 15 people in the tent. Even simple things like washing the hands and with clean water and soap are not readily accessible in these camps. So it's very challenging, and it will be more challenging if the virus spread in Idlib or the rest of Syria. If we're talking about Syria in particular, and the whole country, so far there are about 19 cases that were confirmed. Up to yesterday, 2 deaths. No one frankly believe these numbers. Many people think that there are many other cases that are hidden. The Syrian government is well known and have a track record of lack of transparency. These numbers are used for political reasons. I spoke with some of the physicians in Damascus, and they were telling me that there are many cases that have a typical presentation of COVID-19, end up dying, but they are asked not to talk about it in public. And they're threatened that if they talk about it in public, they will have consequences. Some of them were detained, like the head of the Al-Mujtahid hospital when he talked about that a few weeks ago. So in Idlib province, we have 3.5 million civilians. As I mentioned, half of them have been displaced from other regions. The healthcare infrastructure has been destroyed. More than 50% of the doctors in Syria in general left Syria because of the crisis over the past 9 years. You have shortage of doctors, specialists, nurses. You have shortage of hospitals because 67 hospitals in Idlib province were bombed in the recent bombing campaign. 50% of primary healthcare centers are working because of limited resources. Testing of the coronavirus is also delayed because there's no testing, as far as I know, in Idlib province itself, and unless this changed recently, every suspected case have to be sent to Turkey. PPEs there's shortage of PPEs, protective shields and masks for the physicians and the nurses, and you already have shortage of doctors and nurses. So imagine what will happen if you have a spread of the virus. That will affect the healthcare worker and will lead to more problems. So all of these things combined, of course, in addition to the fact that you have only 80 ventilators in Idlib province, serving 3.5 million people. In my hospital, we have 250 ventilators. We have shortage of ventilators in the United States. So imagine if you have large number of displaced people end up needing ventilators. It's gonna be beyond catastrophic.
Thank you so much, Dr. Zaher, for those remarks. Really looking forward to following up with questions at the end for you as well. And just to flag to all of the attendees of this webinar, we'll be collecting questions throughout the next 50 minutes, and we'll be asking questions to all of our panelists following their remarks. So please feel free to shoot those in the chat box as they come to you. So our next speaker is Dr. Naser Almhawish, and he is the surveillance coordinator of the Early Warning Alert and Response Network, or EWARN. He is a graduate of Aleppo University and has specialized in general surgery, and he also has a master's of public health. He's been working as the surveillance coordinator for EWARN, which is a division of the Assistance Coordination Unit, since 2015. And now EWARN is in charge of surveillance at the COVID-19 task force for Northwest Syria. And Dr. Naser is an active member of this task force. So Dr. Naser, passing it over to you.
Thanks, Kate. Thanks for everyone attending this webinar. In fact, EWARN has been acting as the sole surveillance actors in northern Syria and all areas out of regime control since establishment in 2013. And we managed to be the ones who detected the two polio outbreaks in 2013, 2017, among other outbreaks in the area. As for COVID-19, since the start of the cases in China and Wuhan and the global concerns of spread beyond China, we've been monitoring the situation. And we followed up all documents, all researches that started to be published step by step in the area, even before the spread reached the Middle East. Through that time, we've been looking into ways to find how can we detect this virus if it manages to get to Syria. And unfortunately, at the beginning, there were no commercial kits, diagnostic kits that could be used. The capacity for the labs to be able to detect the virus were very high, and they are, of course, out of our reach. We're still not a government power at that point. Later on, and step by step, start to spread more, and we managed to know that a Turkish company started to produce commercial kits for diagnosis. At that very moment, we started our negotiation to have a training about this, and luckily, we managed to do it. It was just one PCR machine with one lab specialist to be able to run the needed test in all of the areas, and this is the sole place to detect it in northern Syria as a whole, aside from Damascus and Aleppo city, of course. Now, at the moment, surveillance-wise, we are following specific case definition. If the case meets the case definition, specimen will be collected and tested. At mid of last month, under the health cluster in Gaziantep, a task force was initiated and established. It contains WHO, UNICEF, some national and international NGOs like SAMS, Seymour Relief International, and ourselves, in order to have a preparedness plan for response for COVID-19 if it happens in northwest Syria. We are in charge in EWARN for the surveillance and lab pillars. And at the beginning, we just purchased a few kits, 3 to be specific. Each one can run 100 tests, and we wanted to have it as fast as possible. We didn't want to waste time with waiting for some bureaucratic process until we get them. And when they reached the field, we had a relief that, okay, at last we can, if there's a suspect case, that we can test for it. And then it started to increase the amount for the kits, and we have now more than the ability to test 6,000 specimens almost in that one lab. So far, more than 100 specimens were tested, and luckily, all of them are negative for COVID-19. Still, we are not that relieved of this because common sense wise and epidemiological wise, the virus is all over the area. It's in Turkey, it's in Iraq, in Lebanon, Iran, Jordan, and of course cases detected by the Minister of Health in Damascus. So we are afraid that the virus is still circulating in the area and underdetected. Therefore, we're trying to be as sensitive as possible to detect it with some measures that I'll talk about soon. The task force in general is supervising and trying to plan and coordinate between all the partners in the different pillars, starting from the risk communication, from the coordination between the partners, communicating with the communities and the healthcare providers, the point of entry, surveillance and monitoring. Either it's a cross line within Syria itself due to the different controlling forces in the area, or cross-border between Syria and Turkey specifically. The management, which is one of the toughest part, and how to deal with suspected cases medically or isolation-wise. Also we're talking about the logistics and how to coordinate all those things. So far, the task force has been meeting regularly, at least twice per week, but still there are some slow development in some of the pillars. We are at the moment, what we are trying to do surveillance-wise is to increase the number of tested cases, just in case if we have low transmission of the virus to be able to detect it, even so. We are trying to be more tough, more aggressive when we look at the cases. So if we have the minor suspect of a case, it will be sampled and tested. And let's see what will happen. We managed to double the number of collected specimens in the last few days, and the numbers will be increasing on regular basis. At the same time, we are trying to increase the lab capacity because it's logical that only one lab is serving almost 8 million people. Four of them are living in the Northwest and similar in the Northeast. So we are trying to, in coordination with the WHO and with other NGOs, to establish another lab in Afrin and a third lab in Jarablus. All of those 3 labs will be in Northwest Syria. This way we'll be able to test more specimens and more staff will be working on this. One point that Dr. Zaher mentioned is the importance of the healthcare providers in the area. And that's why we'll start soon, after some negotiation, to test the healthcare providers with high susceptibility to the virus. Those who are working in the ICUs, those who are working in inpatient departments with respiratory illnesses admitted there. So it will be just a sort of contribution and a way to screen regularly, either every 7 days or fortnightly, for those with a higher risk than others to be infected, even if they are asymptomatic. And by this, we are also hoping that if there is a lone transmission, that we can detect it from other source. As I mentioned, so far the lab capacity is still minimal. We are able to test between 30 to 40 specimens per day, and we are hoping that this will be faster in the future. This is not an easy thing, especially when we are talking about area with more than 1.2 millions living in very crowded camps. It's not easy to communicate with them and tell them that please wash your hands regularly. The first thing that I respond, okay, give us water. The wash role here is very critical, is very important, and not just telling people to do it. One of the other activities that we tried to overcome one of the challenges related to the distribution of IEC materials is that we told the task force and the other partners that we do not want any printed materials, because it's illogical to have a source of infection and movement between each one of them. So we opted for the electronic formats for those materials. We faced for a short period of time a problem with the specimen transportation, because you know that at least 3 controlling forces are in charge of northern Syria, and each one of them considers that it's its own country and they have their own borders. So they issued all of them some orders to close the crossing points, but we managed to get permission for our logistic staff to be able to move from area to area, and specimens are still running smoothly. Through our experience in AFP surveillance, we are trying to use the lessons learned from AFP and COVID-19. So utilizing active surveillance approach also, we are looking at the community focal points, informants, just to get any information from the field itself, and trying to utilize the network that we built for AFP for COVID-19. We know that it's overwhelming for our field staff to do all this work. One of them just collected more than 20 specimens all by himself. Did the epidemiological investigation, filled the investigation forms, and shared the data to us only in 1 day. So we know how tough it will be for them. And we are trying to increase the number of the field staff just to minimize on them. This is in brief what's been done surveillance and lab-wise, and we're ready for questions later on. Thanks, Kate.
Thank you so much, Dr. Naser. And then our final panelist will be Hazem Rihawi. Hazem is the Senior Programs Manager for the American Relief Coalition for Syria, ARCS, and he is a pharmacist who graduated from Aleppo University in Syria, and he also has a Master's of Public Health from the Johns Hopkins Bloomberg School of Public Health. Hazem has 9 years of progressive work in the pharmaceutical industry and over 6 years of extensive leadership experience in humanitarian responses, focusing on health and coordination. He's the former co-lead of the health cluster serving northern Syria, and he's also the former health cluster coordinator for Somalia. Turning it to you, Hazem.
Thank you, Kate, and thank you, Naser and Dr. Zaher, for all of this. Dr. Naser has already told you about all of these issues that are related to COVID-19 health response. I would like also to talk about the effects of COVID-19 on other sectors. As you know, we are talking here about a crowded area of multi-displaced people of nearly more than 8 million in the north in itself, between northwest and northeast of Syria. So the preparation for COVID-19 has been ongoing. We know that our Syrian organization and Syrian staff are starting to look into that, but it's quite an uneasy thing to do. We are talking here about a population that is wide dispersed all over there, and at the same time they are crowded in these camps. Nearly 1 million of these people have been displaced multiple times throughout the conflict. As far as we know, the needs for the other sectors have been trying to build up their responses between the camp management and other sectors. These COVID-19 preparation and all of these affecting other aspects, including education, for example, where students and children are lacking in terms of, because schools have been closed in preparation for COVID-19, and we are very worried about the status of education level that will be done, especially that there is minimal level of usage of telecommunications with the population in itself. Food security is also a worry for all of us, since especially the most anticipated response is to ask people to isolate, and these people rely on humanitarian deliveries and day-by-day work. So it's also very, very difficult, and we are asking the humanitarian community to step up all of this. In addition, WASH activities has been increased and been looked at between all partners, distribution distribution of hygiene kits, but still it is a lot problematic with all these circumstances compounding all. So in essence, we are facing an unprecedented situation where a hidden virus is trying to affect everything, and in a very, very tough situation. I also want to highlight the issue about the situation in Northeast is that we are talking here about 1.8 million people in need of assistance, of health assistance specifically in Northeast. The latest estimation information indicates that there are only 27 ventilators in around 8 public hospitals and only 30 ventilators in private hospitals. There are still no kits and PCR there, and all samples are sent to Damascus via WHO with negative results still now, but it's very, people are questioning the numbers there. Camps in Northeast also are a very dire situation, and the camps are overcrowded and medical points are only serving normal cases with limited staff. Also, in addition, medical equipment and disposables are scarce, and the prices of masks and hand sanitizers are very, very high. The cross-border, as many colleagues from NGOs would know, that the border between KRI, the Kurdish regional territory in the north of Iraq, has been closed as a preparedness for COVID-19 for themselves, but that has cut off the connection for the areas in the northeast. So it's also a very dire situation in that sense. One thing also we want to add is that cross-border, as you can see from all our colleagues, cross-border operation is very, very important for us to ensure that the operation goes smoothly, that EWARN receives and able to implement their surveillance quite readily. But unfortunately, as you all know, we are facing an issue with the renewal of cross-border UN resolution, with the Russians and the Chinese vetoing it, or at least threatening to veto it. The current resolution ends on July 10th, and this is very, very critical in these times, that cross-border should be more open. So this is also is kept in our minds while we are working in the US between DC and the UN agencies. So that's in a nutshell what we have been working on. And I go back to you, Kat.
Thank you all so much. This is such important information, and it's wonderful to get the updates from some of the best sources out there. We've had some really good questions being sent in to both the Q&A section down at the bottom and through the chat. So I'll begin with some of the questions that we've been getting, and I encourage anyone else to keep entering questions, and we'll try our best to answer as many as possible in the next half an hour. So the first question to this group is, how is the international humanitarian community managing accessibility into Idlib? You sort of just touched a bit on this, Hazem, on some of the challenges, but if any of you want to elaborate.
Maybe I can start with something, and then Hazem and Dr. Naser can add to it. So, of course, for the people who are not familiar with what's unique about the Idlib province, it's a province or governorate in the northwest of Syria that has a population of 3.5 million. Half of them have been displaced from cities like Aleppo, Deir ez-Zor, Dar'a, Homs, Ghouta, Damascus, and other places. It is controlled by opposition groups, and they control who will get into the province. The only entry of the international community or international aid to Idlib is through the Turkish border, and there are two border crossings, Bab al-Hawa and Bab al-Salama. And these are the only way that humanitarian assistance, medications, medical supplies have been getting through Idlib. Of course, Idlib is connected to the rest of Syria, but there is minimum, as far as I know, exchange of medical and humanitarian aid from the rest of Syria to Idlib and vice versa. And of course, if Dr. Naser has other information, we call this cross line humanitarian assistance compared to cross-border, which coming across the border from Turkey. That's how humanitarian assistance are reaching Idlib. And then I'm sorry to mention this, but the United Nations Security Council a few years ago legalized this process of cross-border relief by United Nations Resolution 2254, which has been renewed every year. And in the beginning of this year was renewed for 6 months. So it will end practically in June. And if it is not renewed, that means there is no legal way under the UN auspices to send humanitarian assistance through the Turkish border to Idlib. It doesn't mean that it will stop completely, but it will limit the amount of humanitarian assistance that comes through the Turkish border.
Hazem or Naser, anything else to add to that?
No, Dr. Zaher thankfully covered the overall idea of this topic.
Great, then we have another question. What organizations provide medical supplies to Idlib province? I think we can all probably answer a bit about that, but Hazem, do you want to begin?
Basically, I mean, the main component of all the response inside Syria are the Syrian NGOs. So it's the Syrian NGOs and the Syrian staff that they are doing the whole work, of course, with support from UN agencies and our colleagues from international NGOs. We have multiple entities, including, for example, MedGlobal, SAM, Syrian American Medical Society, SRD, Syria Relief and Development, in terms of health. And they were quite I mean, they were really doing really excellent job in there. In terms of other sectors, we have, I mean, we have other entities that have been doing between what we have there. We have Violet Organization, Mulham Team, all of these local NGOs that have stepped up really, really good and supported us, all of this. Big Heart also has been really supportive, all of this. Syrian Forum. Most of us Syrians, we have been taking the lead on the ground, taking the risk, all of this. And that's why we always, while we, of course, thanks all our international NGOs that are supporting, but we think that Syrians have done quite an amazing job in doing all of this. So that's why we always ask for support for local organizations.
Yes, absolutely. Just to echo Hazem, the organizations that are members of ARCS, the American Relief Coalition for Syria, are doing amazing work on the ground. We at MedGlobal are partnering with the Violet Organization and OSAM to take a really active role in this response. So another plug for direct funding to Syrian NGOs.
I may add that there are many other Syrian organizations and also international organizations that are supporting the humanitarian assistance in Syria directly or indirectly. Rahma Worldwide, for example, is one of the very active organizations in Idlib. Violet, of course, and Mulham, as Hazem has mentioned, is some of the not only humanitarian organization, but also grassroots civic organization that also work to empower youth, empower women, provide education, spread the public health education, all kinds of things that are necessary in a situation like this, disasters like this. I think also it's important to mention what's unique about the Syrian crisis, that in any other crises, you usually have physical presence of international NGOs and their staff in the country that has disaster, whether it's the Congo or Yemen or Bangladesh. You will see actually expat who represent MSF and IMC and IRC, the big NGOs, Mercy Corp, Save the Children, that usually have huge funding from states and so forth. In Syria, we did not have that. So what happened that the international NGO kind of shifted the risk to Syrian NGO. Of course, they supported them with funding and stuff like that, but it means that they did not take any risk in delivering humanitarian assistance to Syrians in much need. That risk, unfortunately, caused many harm to Syrian humanitarians, including doctors and nurses. More than 920 doctors and nurses were killed in Syria. More than 580 hospitals were bombed in Syria. And fortunately, we did not have expats in Syria, humanitarians killed in Syria, except for few. But many Syrian humanitarians died because of this conflict. And to me, this is also unethical, because there should be equal distribution of risk between international humanitarian organizations and Syrian-based humanitarian organizations.
Yes, thank you for saying all of that, Dr. Zaher. And I mean, to echo one particular point, I do think that in the COVID-19 response, this is a really important moment for all of the major INGOs and UN agencies to take another look at the policies around duty of care, the obligation to provide a reasonable standard of care for staff who are engaging in dangerous work, and protection for local Syrian partners who are on the ground, like you were describing, actually at the forefront of this response. So thank you very much for all of that. The next question, is there any concern that the regime sees the spread of COVID-19 through prisons as futuring their plans? That is there any indication that the regime would be happy with the outcome of detainees dying? And it would be great to just hear from this panel about the conditions within Syrian prisons and how these are really breeding grounds for the potential spread of COVID-19.
Dr. Naser, would you like to to touch this issue?
Okay, my part is the areas out of regime control, luckily. But yeah, as far as we know, this regime, they'll be more than happy to lose more of the detainees with them, and they are helping it in the inhumane conditions that they are putting them into prisons and into jails and everything. So yeah, they will be more than happy. And they, when I think, I don't know who said that, but one of them, when asked about releasing all the political detainees, they said, we do not have any political detainees in Syria. So you can imagine anything from this regime.
Let me add a few more points. And, you know, in discussions like this, you don't want to be political. But unfortunately, everything is politicized, even with the context of the coronavirus, and this is well-known fact by now. The government changed the numbers based on what they want to gain out of the numbers. They either underestimate the numbers if they feel that high number may cause public pressure against them, or they increase the numbers because that may be translated in international humanitarian aid to them. So, but also in Syria, I mean, it's well-known fact that there's large number of detainees, and these numbers estimate between 125,000 to 250,000. So these are huge numbers of detainees, crowded in many prisons, but the people who left these prisons and survived the experience, they all had the same narrative, that you have small rooms that has between 50 to 60 people. Small rooms, I mean 5 by 10 meters. We're not talking about big wards. So imagine that you have these small prison cells where you have 80 people or 50 people who are breathing on the neck of each one others. And let's say that one of them contacted the coronavirus or any other infectious disease. Everyone else will be died. The second thing that you have, most of these prisoners have already malnutrition, have been tortured. So they have lower immunity to fight any infection. Many of them have died. I mean, it's well-known fact, and I think people who are familiar with the Caesar pictures know that at least 30,000 people were documented as died under torture in the prisons. That's a few years ago, not now, 30,000 with pictures, names, and numbers. So people estimate that you have, on a daily basis, many Syrian prisoners dying because of infections. And if the coronavirus spread in the prison, then that would be catastrophic. The third thing, that of course, that there's no healthcare or quality healthcare to prisoners in Syria and other countries, of course. I mean, in Chicago, we have prisoners who came to us with respiratory failure. They were in the Chicago prisons and they came to the hospital. We put them on the respirators. In Syria, there's no respirators for prisoners. If they got infected, they may get some Tylenol, but they will die.
Yeah, thank you. I mean, that's a very important and jarring reality check about the conditions of the prison systems in Syria and beyond. So we're getting a question if counterterrorism and sanctions rules affect getting general supplies, equipment, etc. into northwest Syria, and are rules being relaxed. I know, Hazem, we had talked a bit about sanctions, if you want to begin, and if others want to jump in.
Yeah, I mean, in general, the northwest of Syria and northeast, I mean, the northwest in Syria have been receiving funding and receiving supplies usually quite regularly. The issue comes from supply chains. As we know, everybody that in COVID-19, the issue comes with the global supply chain issues, and that's hindering the even sending more PPEs and ventilators and even hand sanitizers to inside Syria. So it's a global thing we were talking about. In terms of sanctions against with the government of Syria or in general, it is there has been calls, we have heard about the relaxation of this, and of course we support any measures that will help alleviate the people's everywhere inside Syria, the suffering of these and the preparedness for all of this. But the issue comes is that unfortunately we are dealing with a regime that has shown time and again that they will exploit such things. So what we have been trying to advocate, and we will try, is more of a principled response, where such kind of response that is being implemented will be controlled and audited in a proper way, where we ensure that whatever things that will be sent to prepare and respond to COVID-19 in any area, like in general, should be monitored, and especially make sure that the needs, that the whatever support that is being used is used for the people that are in need. So in general, like while we definitely would love to help everyone, we want that to be principled and to be accountable and to make sure that no one benefits from this kind of surge of all of the needs inside Syria.
Then we have a question. Could we please speak to the state of awareness and prevention measures among the population, and which parties have the capabilities and legitimacy to impose restrictive measures?
Okay. I think I can cover partially this one. The awareness-related activities has been conducted by almost everyone working in northern Syria and as a whole. All organizations, they want to contribute, and they contributed either through awareness sessions amongst the community, distribution of some IEC materials, developing messages to be delivered to the people, either through radio, some station, some TV station, although it's not that very effective because most of the people do not have access to TV in northwest Syria. UNICEF have been also trying to adapt whatever messages they can work on. Through the task force, one of the pillars is to include the community health workers as messengers to deliver those awareness messages to the people in their communities, with choosing some focal points at the sub-district level based on the number of population in the area and the distance, etc. And then a cascade will follow to lower level of focal points, those who will go to the communities and start some awareness sessions. Although we tried all the time to advocate for the fact that we need to make as less as possible those gatherings. The crowded places should be avoided totally. Try to keep people at their houses and try to talk to them, taking care of yourselves and them at the same time. There are no 1 or 30 in the area, unfortunately, and it's not easy to ask people to stay at home because they have other things that they are concerned about. They want to eat at the end. And some of them, if the main supporter of the family, if he or she didn't work for one day, maybe they will not have food for that day. So it's not an easy thing. to raise the awareness, even if they know that it's could be fatal, it could be risky for them, but they have higher priorities. Everyone is trying their best, and we hope that the people will cooperate more and more on those regards.
Great, thank you. So another question, limited trade and civilian movement continues between the Northeast and Northwest. Has there been any contact or mediated contact between the two zones to coordinate a COVID-19 response?
I'll go first, and then maybe Dr. Zaher and Hazem can share their ideas. As far as I know, no, nothing like that. They just closed the crossing points between Northeast and Northwest, and that's it. They have their own administration, the self-administration in the Northeast. They have their own rules. They issued a curfew since mid-March until this day, and it's been extended. They have their own health authorities, and they are doing whatever they want. Coordination is not at the best between the Northeast and Northwest. We are working there in surveillance in Northeast also, and although we managed to continue our activities, but we know that it's not an easy topic. For the Northwest, it's also multiple actors and multiple authorities working there. You have the areas with the Syrian troops supported by Turkey. They have their own rules and their own agenda and their own plans. People and areas in Idlib, they have their own different multiple authorities. So it's not an easy thing even to imagine a panel to coordinate between all those actors. Not an easy thing, and well, we hope that in the future something may happen to facilitate this.
And the only thing that I'd like to add is that Northeast is two Northeast for people who do not know. There is the Northeast that Dr. Naser has mentioned, which is under the control of the Kurdish administration. And then also the Northeast that is under the control of Turkey. That includes the Euphrates Shield, the Olive Branch, the Spring of Peace. And this is the small strip from northeast of Syria that is connecting to Idlib. And potentially that area, that small part of Northeast and the northern Syrian border, which probably has about 1.5 million people, and correct me if I'm wrong, is connected somehow to Idlib, and Turkey has some influence in coordination among these two areas.
Yeah, you have the northeast area between Tel Abyad and Ras Al Ain. Mm-hmm. It's just an isolated island so far, and unfortunately, no cross-border activities are conducted from there. And you have the northern Aleppo parts between Jarablus, Al-Bab, Azaz, and Afrin, also under the Turkish support. That makes it even more difficult to coordinate between the northeast, as you said, under the self-administration, and the northwest in Idlib and western rural Aleppo.
Yeah, I mean, just to add to all, to Dr. Zaher and Dr. Naser, it is unfortunately the reality, the harsh reality of the Syrian crisis is that it's mostly we spend most of our work in negotiations and in allowing all of these coordination efforts to happen. That's why we try our best in all levels to make sure that we think about all of these levels of negotiation and make sure that we coordinate. We try to do that with multiple parties and with the UN agencies. Not an easy task, as you can hear from everybody. So just to highlight that this is why it is important to support more and more the Syrian local NGOs and staff.
And somewhat building on that, we have another question about cross-border assistance in the resolution. So given the importance of the cross-border resolution, can the panelists elaborate on what Syrian NGOs are advocating for, i.e. a technical rollover or adding additional crossing points? And can the panelists talk about attempts to include Tel Abyad would the inclusion of Tel Abyad contribute to access in northeast Syria?
Hazem, you want to?
I'll start. I can start with this also
Yeah.
because I am from the northeast. I know the area. So think with Tel Abyad border gate, yes, it would be great if the resolution included Tel Abyad because in that area at least 200,000 people are living there and they've been cut from everything, really everything. No proper medical care so far, no proper vaccination activities, access to basic needs is gone. It's not there. So having that border gate included in the resolution, it would be a great thing and an opportunity. And the other thing will be that it's not that easy to cross to the other areas in the northeast, like Al-Hasaka, Raqqa, and Deir ez-Zor, but it's possible. So this will facilitate very much the movement to that area if proper negotiation was conducted with the Turkish authority, because you know the sensitivity of the between Turkey and the Kurdish forces in the northeast. So hopefully, yes, I really hope for humanitarian aspects to include Tel Abyad in the coming resolution.
How about Al Yaqubiyya border crossing between Iraq and northeast?
Yeah, this would be great, but at the same time, it's not easy because the UN aids coming from there are almost null because for the UN agencies, they consider that it's an accessible area from Damascus. So from Al Yaqubiyya, it's more for the NGOs more than the UN aids. That's why it was easy for them to remove it from the previous resolution. If it comes back again, yeah, sure. It would be even better than just one border gate from Tel Abyad.
I mean, also from this side, it's both things. Whatever will facilitate more access for humanitarian aid to allow unfettered will definitely be an important thing. We are working with everyone, with our colleagues here in DC, with international NGOs, about looking into the best aspects. I mean, we would love to return back to the 165 where it covers more crossing borders and everything, but we also, unfortunately, we are facing a reality where Russia and China has a veto in the Security Council. So we need to be realistic about what we can push. But in our work and what we have been trying to do and advocate a lot is to allow unfettered access through all access points, even including, especially with Tel Abyad, Yarubiya, and all of these, and whatever that will allow unfettered access. Unfortunately, cross-line interventions has been proven to be not doable, unfortunately, because the government of Syria has removed so many supplies so many times. They restrict the movement of even UN staff and NGOs to be able to access areas even under their control. So that's why we have been advocating a lot for cross-border, because it is unfettered, because it is accountable, because it's more supporting the grassroots and the Syrian NGOs. That's why we have been advocating a lot on this. In terms of all of these, anything that will help will be important for us.
And so we've gotten, I mean, there's been several additional questions about 2165 and the importance. So I would just pose the question, I mean, I guess I would just pose the question to all of you. Can you describe the importance of 2165? And can you describe the reality that could occur if it's not renewed? And I believe it's up for renewal for July 10th.
I can start with that. Simply, it is the U2165 is allowing the UN to conduct cross-border. So while NGOs and INGOs and Syrian NGOs, our colleagues, have been doing cross-border since the early days, since 2012, that resolution has allowed the UN to contribute more and more. They are, in the end, our partners. And as we know, WHO is the leader of the pandemic response. So any cut of that cross-border would definitely be counterproductive rather than, it will not suddenly not allow any access. We definitely will keep doing our work as Syrian NGOs and even as Syrian people. The issue comes back is that the technical details and even the funding through the UN that comes with that will probably be affected. We are trying our best to negotiate and allow all of this to happen, to continue to happen. But especially now when you look at how COVID-19 is being led by the response, which is why the World Health Organization is being created, is to lead and support all of this. That kind of cutting will hinder all responses that can be built up, whether it is with the health response, with mentioning WHO and other entities with the UN. So it's definitely an important piece that we have been always, and we have been working with a lot. And of course, while we criticize the UN generally to make it more, to act more in a better way, but it doesn't mean that they are the leaders, they are the technical, that's why they are there, and we rely on all of this. So all in all, it is important, and we definitely would want that to complete, and even to complete doing that, putting in mind that the cross line, unfortunately, through years, through experience, has proven very unrealistic, unfortunately, with such the government of Syria hindering everything. Putting in mind, and Naser can contribute, remembering the days of the polio, where the response for the polio was delayed because the government of Syria could not and did not do the declaration of that polio has returned. Naser, if you want to contribute on that.
No, you totally covered the point, and thank you for mentioning the polio example, and not just in 2013, where SU and the Syrian NGOs conducted the campaigns, because the mosque said that we have access, we are doing everything, and there's no need for anyone else to interfere. But it was proven that no, they are not. The coverage was very low. Same thing we encountered in 2017 with vaccine-derived poliovirus type 2 outbreak, and we were not able to conduct anything because the vaccine from this type should go only and solely to the Ministry of Health. That's why we just concentrated on the surveillance part, and although we know that the campaigns were not as they should be, luckily the circulation of the virus was interrupted. So the cross-border resolution is very essential in the coming period of time, especially with the COVID situation and even after that.
One more thing that I'd like to add to this is, besides, of course, the possibility of infections due to lack of vaccination, we've seen that through the polio epidemic in Syria and the delay in response from the government. We've seen also the children of Madaya and Zabadani and Ghouta who had severe malnutrition because that the government did not let baby milk get into areas under siege. We published a report in SAMS called Slow Death, Life and Death in Communities Under Siege in 2015. And there were at that time 1.5 million Syrians under siege by their own government, that the government did not allow, according to the UN reports, less than 5% of the UN approved shipment of food and medicine to areas under siege. And that led to malnutrition, led to many people with chronic disease dying because lack of medicine, patients with dialysis not getting dialysis in Ghouta, and many other issues. So we don't want this nightmare to happen again in Idlib. And you have 3.5 million people who are concentrated in a big prison that is landlocked. So definitely everyone who has conscience should be supporting renewing the cross-border relief to Syrian civilians.
And it's nearing noon. There's a few other really good questions. Do you three have the ability to continue for another 15 minutes?
Fine by me.
Yeah, fine by me.
Okay, yes. We'll cover a few more questions. One of them is the WHO's role has been called into question throughout this entire crisis. What role has the WHO played in facilitating the necessary resources needed for the significant refugee and IDP populations in Syria?
I
Dr.
start from
Naser.
my part and then Hazem can elaborate. From our side, we know from the beginning we knew that WHO and the UN agencies have their own rules and they need to follow it. It's not as flexible as NGOs may be. And that's why we started with purchasing the diagnostic kits immediately and waited for WHO afterwards. But from our side, they provided the needed help in providing the diagnostic kits for us, and we are in negotiating with them about establishing a new diagnostic lab in a different area that will serve more of the population. Yes, we lack the technical support from them, and we are doing it by ourselves because we know that all the expats with them are overwhelmed with the situation that they have. So we use our own resources for training materials. We develop them by ourselves and so on. I can understand the critique for WHO's approach recently in Syria, and it's been a long thing. It's not new at all, but and it's mainly related to the management part, to providing the ventilators, the equipment for the hospitals, and so on. But this is not their own sole problem here. But the fragmentation of efforts by all the actors in the field is the main problem, in my opinion, not just the WHO's. It's everyone's fault. Everyone is trying to do everything on his own is to be considered here and should not happen. Coordination is a must here. And yet I totally understand, and it's totally justified for me, those attacks happening on WHO for this. Maybe Hazem can add more ideas.
Yeah. While we always criticize WHO, it doesn't mean that we are against in that sense. What we want, what we have been acting for the longest time, is that we want more principled role that WHO has been created to look at and for such kind of these things. And it is always, we always felt sad that we need to put them under the microscope time and again to make sure that they are doing the best that they can. It doesn't mean they have excellent staff, they are trying their best, but in general, what we have been asking time and again is that we have a situation where WHO should be more flexible in terms of its mandate and supporting the government. We are in a situation where unfortunately we have a government that is part of the conflict, that is acting against the people, and we want them to be more principled and be flexible in doing all of this. That's why we keep pushing them time and again to be able to do their best. That doesn't mean that, oh, for example, we think that they are doing a very, 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 very bad job. No, they are trying their best, and we know, and we meet with them, and we sit with them, and we coordinate with them. That's something that we always ask for. The issues come back is that how principled they are, we want them to be, and to feel the urgency of the needs that we as people that are coming, the three of us now, and Kat, you also included, we feel the needs of the people all the time, but we are desperate for all the support. And when you see the slowness and the time that it takes for things to happen, it makes us very angry, and that's why we keep pushing WHO. Not because that we like criticizing, but it is because we want them to feel the needs of the people that we always hear. We send just 1/10 of what we hear always from our friends in the country, but we want them to be more urgent. That's why we send letters to WHO. We keep pushing them in the regional level, in Geneva, asking them to be more and more in urgency for such contexts and other. Dr. Zaher, if you want to.
I just want to add one thing. I think everyone knows what Albert Einstein said, that the definition of insanity is to do the same thing and expect different results. The WHO office in Damascus, and led by Elizabeth Hoff, has been doing the same thing in the last 9 years, expecting different results, and it's not happening. We've seen the polio epidemic, we've seen the children of Madaya and Zabadani and the children of Ghouta, we've seen the attacks on healthcare providers in Aleppo and Idlib, hospital bombed, doctors killed, and so forth. The criticism for the office in Damascus of the WHO is yes, we know that you would like to have every Syrian having access to healthcare, but you need to do things differently because this is not a normal conflict. This is a conflict that the government is using medicine to kill people, is weaponizing medical care and healthcare. And you have to be present in the ground. I haven't seen any presence of the WHO officers, and correct me if I'm wrong, in Ghouta under siege, or in Zabadani and Madaya when children were dying of malnutrition, in Aleppo when hospitals were bombed, or now in Idlib. So the first rule as a humanitarian, you have to assess the field yourself, not only depend on NGOs and technology to see what's going on. And that's why we're seeing very delayed response by the WHO to what's happening in different parts of Syria because they are not present on the ground. All UN agencies have to be present on the ground. In the last, a month ago, before the crisis of COVID, we have seen the first visit of UN officers to Idlib province in the last 9 years. And this is, to me, is unfair, unethical, and unconscionable from an agency, the UN and its agency, the WHO, that are supposed to provide healthcare and protect physicians in time of crises and disasters.
Thank you all. One really important question about northern Syria in relation to Turkey. So in the last couple of months, as many as 7,000 Turkish military personnel have entered Idlib to man observation posts, and more continue to circulate in and out. Are there any steps being taken to avoid these personnel inadvertently bringing COVID-19 with them?
Usually, they do not go to the local health facilities. They don't interact in general with the locals in their areas, especially in the last couple months. So they are somehow isolated in their areas with minimal or no connection. But at the same time, we have some, especially at the border gates, where some Syrians are still crossing the border between Syria and Turkey, which is a risk factor for us. And we investigated and sampled and tested some of the cases that had contact with the Turkish side, or they were in Turkey beforehand. This is one of the criteria of the case definition, that a person with a symptomatic person coming from an area with confirmed circulation. And from this, the importance of that. Related to the soldiers, the interaction is minimal as far as we know. And we hope that they will be contained in their areas with minimal movement on and off.
Okay, thank you. Another question for you, Dr. Naser. You mentioned that they chose to use electronic IEC materials to limit possible transmission via physical materials. How do you ensure you reach those who cannot access electronic formats for whatever reason? Illiteracy, not having a mobile phone, lack of internet, etc.
Okay, in general, this approach is to minimize the distribution of solid hard copies. We even have a WhatsApp number that people can access to. The majority of the people in the Syria, and Dr. Zaher and Hazem also knows this, that they use WhatsApp more than anything. And satellite internet is available almost everywhere, even in the camps. This is one of the first things that they do, is try to get internet access because it's the only connection out of their areas. At the same time, our field staff also is doing some awareness sessions at the community level about the proper techniques for hand washing, to try to minimize contact between people, to advocate about not to go to the markets in bulks, minimize this kind of movement. It's not an easy thing. And we know that, and that's why we're trying to facilitate this. It's either EWARN ACU or the other partners in general. We try to go to the community level. Even for the surveillance training that we are conducting at the moment, we opted for a health facility based approach, where our staff would go to the health facility, People will be in their PPEs as much as they can, separated from each other, and we conduct the training, even if it needed 2 or 3 sessions to finish all the staff in the health facilities. You need to be innovative. You just cannot go with the simple and easy options with printing 40,000 brochure and distribute it, and you say that, okay, I'm done. We are trying our best, and we will keep developing it on a daily basis if needed.
I just want to mention about one aspect of communication in Syria in general, and in Idlib province, Northwest in particular. With our experience with the medical relief, we have used communication effectively, including WhatsApp. We created WhatsApp group that has doctors in the United States and doctors in Syria to look at patients in the intensive care units and managing these patients. So that's called electronic ICU, very simplified. It was used very effectively in Aleppo, Idlib, and Ghouta and other places where you have doctors sending pictures and videos of their patients, the monitors, the ventilators, to physicians who are based in the US, who provided advice and consultation and so forth. And this is something, frankly, that we have learned from the Syrians, and we're trying to apply right now in Chicago, where we have also hospitals that are underserved, do not have intensivists, and we are creating the same WhatsApp groups that we've created in Syria. Syrian in their use of communication, especially applications, and probably that's more in the region, are more advanced than the American public in using these methods of communication, to their credit, and we are learning from them.
Thank you for mentioning this. Actually, for us, even for surveillance, we are using this even before I started in the program. We have dedicated WhatsApp rooms, one for AFP, the active flash paralysis surveillance, where short videos of the cases will be presented, short history of the case, the manifestation, and we communicate with the field staff with it. And we use it not just to be notified about the cases, it's a way of continuous learning. For those who are new to the program, or those in different areas we didn't manage to do the training. Even the training that we conducted for our district level officers, we did it via Skype. We couldn't bring them, we didn't want to risk bringing them to Turkey to train them. So we established Skype rooms dedicated only for training, and we use that. So I think, as you mentioned, we are more familiar of using the social communication means than others.
And then I'll have this be the final question to the group. Are there any plans for shielding particularly vulnerable and high-risk patient groups to mitigate and prevent the spread of COVID-19 among the most vulnerable?
Okay, from the task force activities, one of them is related to the establishment of isolation centers. And from the beginning, I suggested that we use the cholera approach because, as Dr. Zaher said, that the health facilities were targeted. We have minimum number of health facilities already in the field. So using tents as isolation centers would be a very good approach, even if we reach the level where we established the ICUs in tents, specifically for the suspected COVID cases. That will be also used. It is not an easy thing to isolate people. And the example that Dr. Zaher mentioned, I have few similar stories that happened for cases that we told them, you have mild symptoms, it's negative for you afterwards, but please isolate yourself, try to minimize. And it's not easy. They are living even up to 20 persons in one tent. We are trying to use this isolation centers approach through the task force for case management, and we try to make it known for the people and known to the healthcare providers that please direct and refer those suspected cases to the isolation centers, hopefully to minimize the spread of the virus if we can.
This is very important topic, Kath, because this applies not only on the Syrian context with a large number of displaced, but any refugee camps, like Rohingya refugee camps. We operate in Bangladesh, where you have 600,000 Rohingya refugees within very small areas. mostly camps. In Greece, where you have the Moria camp, 22,000 refugees in a small area. In Venezuela and other places. So what do you do when you know, the population are crowded in very dense space and you don't have access to ventilators or advanced healthcare? So this isolation, containment places or tents, big tents, can serve a purpose here, and it's actually some of the recommendations of the WHO is to do that. And you have 3 types of isolation centers. So you can isolate on the edge of camps people who are at higher risk, and I've mentioned those in the beginning. So elderly people, patients with chronic diseases. I'm not talking about sick patients here, just people who may have higher risk to get the infection. So that way they can maintain some level of social distancing from the rest of the camp. The second part would be to self-quarantine patients who were exposed or who were suspected to have the disease. And that also can be placed in a big tent on the edge of the camp. But the problem that we have too many camps in Idlib. But let's say that we target large camps. And the third level of isolation is to isolate patients with symptoms from the rest of the camps. And this is also can be done on the edge of the camp, a little bit distant from the rest of the camp to prevent mixing. It's not 100%. You cannot accomplish full protection and isolation, but these are things that you can do in the setting of refugee camps to prevent the spread of the virus to everyone in the camp.
Great, thank you so much. So just to close it out, I would love to hear from each of you if you have any final remarks. And to kind of prompt the direction of the remarks, I would also say that I think a lot of people who are participating in this webinar are in the US and in particularly DC and New York involved in the policy space. So as you do final remarks, I would also love to hear if there's specific top needs that you see from the US government or critical stakeholders to best support Syrian people in light of the COVID-19 pandemic. Dr. Zaher, if you want to start first.
So I think that the most important thing is to support these local efforts that are created by the local communities to build resilience within the community. I've seen videos of ventilators produced in Idlib and Al-Bab. Small ventilators, but maybe it can work. You know, we are partnering with MIT, for example, in MedGlobal to see if ventilators that can be made locally in Syria and Yemen and Gaza can be used and produced locally at very small price compared to the expensive ventilators that are not present even in the US. Supporting these efforts for prevention of the spread of the virus within the camps of the displaced and the refugees. All of this needs funding. Having PPEs, protection of healthcare workers in Idlib, is a priority because you already have shortage of doctors and nurses. So sending PPEs or supporting effort to produce PPEs at the local level. So also you can improve economy and so forth. All of these things can be supported by donors, by funders, by US government. And I think it should be a priority because what we have seen in the last 9 years that what happened in Syria is not contained in Syria. And I think the virus also taught us the same lesson, that unless we take care of these disaster regions and we address them, or address the root cause, then things will get out of control and spill over to the rest of the world, whether it's Europe or the United States. So it is to our best national interest in the US, if we're not talking about humanitarian issues here, is to take care of the refugees, to take care of the Syrians. That's why I brought initially UN Security Council Resolution 2254, not 2165, because unless we solve this crisis based on the UN Security Council resolution that calls for political transition and national reconciliation and transitional justice, then things will continue to fester and will continue to face these issues. So we should not be applying band-aids. We should not be just talking about this now and then after a few months, another wave of displacement, after a few months, another disaster. We have to try to address the root cause of the conflict and push for an end of this crisis.
Thank you so much. Dr. Naser?
Yeah, I think Dr. Zaher summarized the whole thing. The need for funds is critical and it's very important. And just for example, only for our staff, the needs of PPEs for around 30 days just for EWARN staff. I'm not talking about the healthcare providers. It's more than $50,000 per month. So you can imagine how much is needed at the health facility level. And if you want to start to those who are sick and they want to go home, they need to have masks as one of the techniques used to protect the others. The sanitizers, the wash-related things, this needs fund. So fund is very critical. Political-wise and policy-making-wise, the cross-border resolutions are very important here, putting pressure on some of the governments, putting pressure on some UN agencies to facilitate and fasten the aid flow to the area is also very critical. Yeah, this is in general what one can think of.
Hazem?
Yeah, I mean, also I would just to iterate one thing that I think is important to look at is that while COVID-19 has exposed shakiness in the healthcare systems all over the world, unfortunately, the healthcare system in Syria has been destroyed. It's systematically looked at it for 9 years. So when we ask for funding or when we ask for all of this, we should be looking also, like Dr. Zaher said, on a policy-wise, on longer-term rebuild of that health system. And the COVID-19 is just one thing that Syrians has coped on, are anticipated to adjust to, and they have been living through that multiple times. We've seen through the 9 years horrors and situations that are beyond understanding, but yet we survived. So what we have been trying to look at that even with COVID-19, the issue comes back to rebuilding the health systems in Syria. And that's what we should be continuing and advocating for all. It's not only limitation to the COVID-19 response, but it's all over. So the country will need rebuilding the systems. We're talking about hospitals. We're talking about medical staff. These are the things that we should be looking at in the future. So that's why we keep asking here that COVID-19 can be a step forward in terms of understanding the needs, but we should be continuous all over and not be limited to only the response, but all over. EWARN has been amazing and critical in all our responses on healthcare. So we definitely thank Naser and the others, but it is important to support them and all Syrian NGOs in that sense to rebuild the country, to rebuild the health system, to allow us to give us the capacity to respond not to this crisis, but all over any other public health emergencies that can come up. So definitely we are with our colleagues and friends from NGOs, and we are, I think in the health sector, we work all together to that same end, and we will keep pushing all of this. So any help, work together, that will be really, really helpful. Thank you.
I just want to mention one thing that is, in MedGlobal, we established COVID pandemic relief fund to support local healthcare providers in Syria, in Gaza, in Yemen, in Bangladesh, with PPEs, with medications, with ventilators in some instances. So I urge everyone to support such effort and also to support other organizations that are working really hard in Syria and other disaster regions. Of course, in the US, in our backyard here, we have also the same healthcare disparity, unfortunately, and we have people who have less access to good healthcare than others. And we've seen that in the COVID crisis, which uncovered these gaps we have in the healthcare system in the US here. So please be aware of people who are in need and be generous, and hopefully we can move beyond this pandemic and talk about rebuilding and recovery.
Thank you. I think that that's the perfect note to end on. Thank you so much for the three of you for being leaders in the Syria humanitarian response now and over the last 8 years. And thank you everyone for joining. Like Dr. Zaher said, we at MedGlobal are an active part of the COVID-19 response. In particular, like Dr. Zaher mentioned, there is a shortage of PPEs, and we're immediately responding right now with the goal of sponsoring 2,500 healthcare workers in Gaza, Syria, Yemen, Bangladesh, and Pakistan with PPEs. So if you're interested in knowing more about that, or you're able to support us in that effort, I would encourage you to go to medglobal.org or our Facebook page under MedGlobal, and would reiterate the call to support organizations like EWARN and all of the organizations that are members of ARCS as well. Thank you all so much.
Thank you.
Thank you.
Thank you.
Bye.